Hello everyone, and welcome. I'm Dr. Asim Hussein, and I'm pleased to have you here today. Today, we'll be exploring neurological emergencies, part 2 of our series. This session will cover critical concepts and management strategies for urgent neurological conditions. We'll look at various emergency scenarios, how to recognize them quickly, and effective responses. So, let's get started and deepen our understanding of these vital topics. Let's walk through the options on this table. First, observe closely. At this stage, no intervention might be needed yet. This is important because not every patient with weakness requires immediate action. Moving to the next option, elective intubation for impending respiratory failure. This would be appropriate if signs suggest the patient's airway is about to fail, but we need to be cautious and base that decision on clinical and diagnostic findings. Then we have trial of non-invasive ventilation, or NIV, to try and avoid intubation. This can be beneficial if the patient is still maintaining enough ventilation, but shows signs of impending compromise. Next, delaying airway intervention until ABG results show hypercapnia. That's when carbon dioxide levels are rising, indicating worsening ventilation, can be a strategic choice. Finally, starting high-dose steroids urgently is crucial, especially in cases like Guillain-Barré syndrome, where rapid immunomodulatory therapy can alter the course of the disease. Overall, this table helps us prioritize interventions based on the patient's evolving respiratory status, aiming to prevent respiratory failure while avoiding unnecessary invasive procedures. All right, let's discuss the key indicators that suggest impending respiratory collapse. When the vital capacity, or VC, drops below 15 milliliters per kilogram, and the negative inspiratory force, or NIF, is greater than negative 30 centimeters of water, these are critical signs. They tell us that the patient is heading towards respiratory failure, and this is the point where we should consider elective intubation before hypercapnia, or elevated carbon dioxide levels, develops. It's important to act proactively in these situations to prevent a full-blown crisis. Also, I want to emphasize that non-invasive ventilation, or NIV, is generally unsafe here. Because of the rapid progression of neuromuscular weakness, NIV might not provide adequate support and could delay necessary airway management. So, to connect this back to our overall theme, recognizing these early signs allows us to intervene timely, ensuring patient safety and better outcomes. Let's look at the different options for disease-modifying therapy in this case. We have several choices here. First, IV methylprednisolone, which is a corticosteroid. Then, oral prednisolone, another steroid option. Next, IVIG at a dose of 2 grams per kilogram over 5 days, a common immunomodulatory treatment in Guillain-Barré syndrome. We also have the combination of IVIG plus plasma exchange, which is sometimes used in more severe cases. Finally, cyclophosphamide, an immunosuppressant. In this scenario, we have a 52-year-old woman with Guillain-Barré syndrome, diagnosed just a day ago. Her weakness is worsening, but she's hemodynamically stable and not yet intubated. The key here is choosing the most appropriate disease-modifying therapy to prevent progression and improve her outcome. Typically, for Guillain-Barré syndrome, IVIG and plasma exchange are considered first-line treatments because they target the immune response directly. Steroids like methylprednisolone or prednisolone, on the other hand, are less effective in this condition and are generally not recommended. Cyclophosphamide is usually reserved for other autoimmune conditions and isn't standard in Guillain-Barré syndrome management. So, in this context, selecting IVIG at 2 grams per kilogram over 5 days would be the most appropriate choice, especially given her recent diagnosis and the worsening weakness. This approach aligns with current guidelines and evidence, aiming to modulate her immune response effectively and prevent further deterioration. Let's take a closer look at the treatment options for Guillain-Barré syndrome. The correct answer here is C. There are really only 2 effective treatments: intravenous immunoglobulin, or IVIG, and plasma exchange. These are the mainstays of therapy, and importantly, they should not be combined. Using both together doesn't provide additional benefit and could potentially cause harm. Now, it's also crucial to understand that steroids, despite being useful in other autoimmune conditions, do not improve outcomes in GBS. They are not recommended for treatment and won't help in speeding recovery or reducing disability. So, to tie this into our overall discussion, recognizing the right treatment options is key to managing GBS effectively. Choosing IVIG or plasma exchange can make a significant difference in patient recovery, while unnecessary or ineffective treatments like steroids should be avoided. Let's look at the management approach for this patient with Guillain-Barré syndrome, who is experiencing fluctuating heart rate, severe labile hypertension followed by hypotension, and episodes of sweating. Starting with the first point, administering beta blockers for all tachycardic episodes can be effective in controlling rapid heart rates. However, it's important to remember that this approach should be balanced carefully, especially in a patient with autonomic instability. Next, aggressively treating all bradycardia with atropine is often necessary, but we need to assess each episode individually. In cases with significant autonomic dysfunction, atropine can help improve heart rate, but we should monitor closely for adverse effects. The third point emphasizes invasive monitoring combined with cautious, symptom-directed management. This is crucial here because the patient's hemodynamics are unstable and fluctuating. Continuous monitoring allows us to tailor interventions precisely to their current state, avoiding unnecessary treatments. Regarding routine IV fluids, they are typically not the mainstay in such complex autonomic cases unless hypovolemia is confirmed. Overhydration might worsen some symptoms, so fluid management must be individualized. Lastly, sedation to suppress autonomic swings can be beneficial. Sedation can help stabilize the autonomic nervous system, reducing the severity of these labile episodes. But again, it should be used judiciously, considering the patient's overall condition. So overall, the key is a cautious, tailored approach with invasive monitoring and symptom-based management, rather than a one-size-fits-all protocol. This helps us address the complex autonomic disturbances seen in Guillain-Barré syndrome effectively. Correct answer is C. GBS autonomic dysfunction can be quite dangerous and unpredictable, so we need to be very careful. When managing these patients, it's important to treat blood pressure swings cautiously because aggressive treatment can sometimes cause the opposite extreme to occur. Monitoring invasively is key here, as it gives us real-time data and helps us respond promptly to changes. And remember, overtreating can worsen the situation, so balance and vigilance are essential. This ties into the overall theme of managing GBS carefully and understanding its complexity to improve patient outcomes. Let's take a closer look at the management options outlined in this table. Option A suggests starting BiPAP early for respiratory support. This approach is useful when we want to provide non-invasive assistance before the patient's condition worsens. Option B involves elective intubation, which might be necessary in cases of bulbar dysfunction where airway protection is compromised. This is especially relevant here, given the patient's difficulty clearing secretions and weak cough. Option C is close monitoring without immediate airway intervention. While sometimes appropriate, it requires careful assessment to avoid delays if the patient's respiratory status declines. Option D combines starting IVIG with the use of non-invasive ventilation simultaneously. This can be effective in managing GBS while supporting breathing without invasive procedures. Lastly, Option E suggests using high-flow nasal cannula instead of intubation. This can be a less invasive way to support oxygenation, but its suitability depends on the severity of respiratory compromise. In this case, with a VC of 18 ml/kg, weak cough, and significant bulbar dysfunction, our key focus should be on ensuring airway protection and adequate ventilation. Recognizing these signs helps us decide whether to escalate support early or monitor closely. This table underscores the importance of tailoring our approach based on the patient's specific respiratory and bulbar function to optimize outcomes in GBS management. Let's look at slide 9. The correct answer here is B. When a patient has bulbar dysfunction, they often can't effectively clear their secretions. This is a crucial point because it directly impacts how we manage their airway. If they can't clear secretions, using non-invasive ventilation methods like NIV or high-flow nasal cannula, or HFNC, can actually be dangerous. They're contraindicated. The reason is that these methods don't support secretion clearance and might delay necessary airway management. Instead, in these cases, elective intubation becomes the safest option to secure the airway properly. This highlights the importance of recognizing bulbar dysfunction early so that we can choose the safest intervention and prevent potential respiratory compromise. Let's look at this scenario. If a patient with Guillain-Barré syndrome is treated with IVIG and remains ventilated on day 5 without any clear signs of improvement, what does that tell us? According to the guidelines, if there's no improvement within 5 days, it's generally considered that IVIG has failed. In that case, the next step would be to add steroids to help accelerate recovery. Sometimes, plasma exchange might be considered immediately after IVIG, but typically, if there's no response, adding steroids is the recommended approach. It's also important to remember that improvement in GBS may begin after 1 to 2 weeks, so early lack of progress doesn't necessarily mean treatment failure forever. However, once a patient is intubated, achieving full recovery becomes less likely, especially if no improvement is seen early. So, in this situation, the most realistic expectation is that if there's no improvement by day 5, the current IVIG treatment is likely not effective, and we should consider adding steroids to help the patient recover more quickly. Correct answer, D. GBS recovery typically begins after about 7 to 14 days. It's important to understand that treatments like IVIG or Plex don't work instantly. They need some time to take effect, so patience is key. And just to clarify, you should not combine IVIG and PLEX treatments at the same time. Using them together isn't recommended because it can increase risk without providing additional benefit. This aligns with the overall theme of understanding how GBS progresses and how to manage it effectively. Let's talk about the diagnosis of Guillain-Barré syndrome. One of the key features is rapidly ascending weakness, which means the weakness starts in the legs and quickly moves upward. Patients often present with areflexia or absent reflexes, which is a hallmark sign. It's important to note that Guillain-Barré is often post-infectious, meaning it can follow an infection like Campylobacter or a viral illness. This connection helps us understand its immune-mediated nature. Another critical point is autonomic instability, which is quite common in Guillain-Barré. This can include fluctuations in blood pressure, heart rate, or even severe autonomic dysfunction, and in some cases, it can be fatal. Because of these features, Guillain-Barré syndrome is considered a high-yield diagnosis in the ICU setting. Recognizing these signs early is crucial for timely management and improving patient outcomes. Let's now look at some key respiratory warning signs to watch for. When the vital capacity, or VC, drops below 15 ml per kilogram, it's an urgent sign that we need to consider intubation to support breathing. Similarly, if the negative inspiratory force, or NIF, exceeds 30, that also indicates that the patient is likely to need airway support, and intubation should be considered. We also need to be alert for rapid progression of respiratory weakness. If we notice a weak cough or signs of bulbar involvement, which affect swallowing and speech, we should avoid non-invasive ventilation, or NIV, because it might not be sufficient or safe in such cases. Now, specifically regarding Guillain-Barré syndrome, which is a critical condition we often see in the ICU, these signs are especially high yield. Recognizing these respiratory warning signs early can make a huge difference in outcomes, so always keep this in mind when managing patients with neuromuscular weakness. Now let's talk about the treatment options for Guillain, Barré syndrome. Typically, we consider two main therapies: IVIG, which is administered at a dose of 2 grams per kilogram over 5 days, or plasma exchange, usually done in about 5 sessions. Both these treatments aim to reduce the immune attack on the nerves and improve recovery chances. It's important to note that steroids, despite their common use in other inflammatory conditions, are not effective in Guillain, Barré syndrome, so we generally avoid them. In addition to immunomodulatory therapy, DVT prophylaxis is crucial because patients are often immobilized and at increased risk for blood clots. Pain management is also key, especially since neuropathic pain is quite common in this condition, and controlling it can significantly improve patient comfort. Lastly, always remember that Guillain, Barré syndrome can progress rapidly and may require intensive care monitoring. Early and appropriate treatment can make a big difference in outcomes, so understanding these management strategies is essential. When managing autonomic dysfunction, it's crucial to treat each episode carefully. This means responding thoughtfully rather than rushing to correct everything immediately. Aggressive overcorrection can actually cause an opposite crisis, so patience and cautious adjustments are key. In some cases, considering invasive blood pressure monitoring might be necessary to get accurate, real-time data and guide treatment more effectively. Now, shifting gears a bit, let's talk about Guillain, Barré syndrome, which is a high-yield topic in the ICU setting. It's important to recognize that this condition can lead to significant autonomic instability, so understanding its management is vital. In summary, whether dealing with autonomic dysfunction or Guillain, Barré, the theme is careful, precise intervention, always aiming to stabilize without causing additional stress or complications. Let's talk about ventilation strategy in this context. When managing patients with conditions like Guillain, Barré syndrome, we often anticipate that they may require prolonged ventilation, sometimes lasting for weeks. It's important to plan accordingly to support their breathing over an extended period. We also want to avoid fatigue, both for the patient and the respiratory muscles, because fatigue can complicate recovery and prolong ventilation needs. Gentle ventilatory support becomes key here. Using modes that minimize discomfort and prevent further muscle weakness is essential. Another critical point is dysautonomia, which is common in Guillain, Barré syndrome. This makes the choice of sedation particularly important, as it can influence autonomic stability and overall patient comfort. By understanding these aspects, we can better tailor our ventilation approach to improve outcomes and facilitate recovery in these patients. Let's talk about prognosis today. Recovery from Guillain, Barré syndrome typically begins after about 1 to 2 weeks, but it can take several months to reach its peak. It's important to remember that needing ventilation doesn't necessarily mean the prognosis is poor. Many patients do recover well. In fact, around 80% of individuals are able to walk again within 6 months. So, while the initial phase can be quite challenging, the outlook is generally optimistic. This highlights how, even in severe cases like those requiring ICU care, the long-term recovery potential remains good. Let's consider the scenario presented here. We have a 42-year-old man arriving with fever, headache, photophobia, and a Glasgow Coma scale of 12. Neck stiffness is also present, which strongly suggests meningitis. Now, the key question is, what is the best next step, especially since the CT head isn't immediately available? Looking at the options, the most important thing to remember is that in cases of suspected bacterial meningitis, time is critical. We need to start treatment promptly to reduce the risk of complications. Option A suggests waiting for a CT scan before any treatment, but delaying treatment in a suspected bacterial meningitis case can be dangerous. Early antibiotics are crucial. Option B recommends performing a lumbar puncture immediately. While lumbar puncture is essential for diagnosis, it should not be delayed if there's a risk of increased intracranial pressure or other contraindications. But in this scenario, since the CT isn't available and the patient shows signs of meningitis, we need to consider the safest approach. Option C suggests starting IV antibiotics and dexamethasone immediately. This is generally recommended in suspected bacterial meningitis because early antibiotics improve outcomes, and dexamethasone helps reduce inflammation and neurological damage. Option D proposes starting acyclovir first, then antibiotics. That might be appropriate if viral encephalitis is suspected, but given the presentation and signs pointing toward bacterial meningitis, antibiotics take priority. Option E indicates doing no treatment until the lumbar puncture is done. But again, delaying antibiotics in suspected bacterial meningitis can be detrimental. Therefore, in this case, the best next step is to initiate empiric IV antibiotics along with corticosteroids like dexamethasone immediately, even before performing the lumbar puncture, especially since the CT isn't available right now. This approach aligns with current guidelines to prevent rapid deterioration. So, to summarize, starting empiric antibiotics and dexamethasone promptly is the most appropriate action here, ensuring we don't lose valuable time in managing this potentially life-threatening condition. Let's focus on the correct answer, which is C. Bacterial meningitis is a true medical emergency. If there's going to be a delay in performing a CT scan, it's crucial to act quickly. In such cases, you should administer empiric antibiotics and dexamethasone immediately, even before performing a lumbar puncture. This approach helps to reduce the risk of neurological damage and improves patient outcomes. Remember, timely intervention is key when bacterial meningitis is suspected, so prioritize starting treatment without delay if imaging can't be done right away. When evaluating a patient with suspected meningitis, it's crucial to identify any factors that might increase the risk of complications from a lumbar puncture. For instance, if the patient shows signs like altered mental status, focal neurological deficits, or signs of increased intracranial pressure, these are red flags. In the case of a 55-year-old man with fever and altered behavior, we need to consider whether a CT scan should be performed before doing a lumbar puncture. The main reason for this is to rule out any mass effect, brain shift, or other contraindications that could worsen with the procedure. Specifically, if the patient has focal neurological deficits, such as weakness or abnormal sensation, or signs indicating increased intracranial pressure, like papilledema, these are critical clues. They suggest that performing a lumbar puncture without imaging could lead to brain herniation. So, in summary, the key factors that would necessitate a CT scan before LP are the presence of focal neurological deficits or any signs of increased intracranial pressure. Recognizing these points helps us avoid serious complications and ensures safe management of meningitis. This step is an essential part of the overall approach to diagnosing and treating central nervous system infections effectively. The correct answer here is C. When considering a lumbar puncture, or LP, it's crucial to evaluate if there are any contraindications beforehand. Some of these key signs include focal deficits, which suggest localized neurological issues. If a patient shows papilledema, that indicates increased intracranial pressure, and performing an LP could be dangerous. Seizures are also a red flag, as they may be related to increased pressure or mass effect. Immunosuppressed patients require careful assessment because they might have infections like meningitis or abscesses that need different management. Lastly, reduced consciousness or altered mental status can be a sign of increased intracranial pressure or other serious conditions, and in such cases, an LP might be contraindicated until those issues are stabilized or further evaluated. So, keeping these contraindications in mind helps us ensure patient safety before proceeding with the lumbar puncture. Let's take a closer look at the table on this slide, which outlines the recommended management options for suspected HSV encephalitis. Starting with option A, ceftriaxone alone. While ceftriaxone is a broad-spectrum antibiotic, it's not effective against viruses like HSV, so it wouldn't be the primary choice here. Moving to option B, vancomycin plus ampicillin. Again, these are antibiotics mainly targeting bacterial infections, not viral encephalitis. Option C, dexamethasone alone, is a corticosteroid, which can help reduce inflammation but doesn't address the viral cause directly. The most critical intervention here is option D, IV acyclovir immediately. Acyclovir is an antiviral specifically effective against herpes simplex virus, and starting it promptly is vital to improve outcomes. Lastly, option E recommends observing the patient for 12 hours to monitor for clinical progression. While observation is important, in cases with high suspicion of HSV encephalitis, immediate treatment with acyclovir takes precedence to prevent neurological damage. In summary, the most important point to remember is that early administration of IV acyclovir is essential when HSV encephalitis is suspected, especially given the MRI findings of temporal lobe abnormalities and the clinical presentation. This approach aligns with the overall theme of rapid, targeted intervention in viral encephalitis to reduce morbidity and mortality. Correct answer is D. HSV encephalitis is a serious condition that can be fatal if not treated promptly. It's crucial to start IV acyclovir immediately, even before we have confirmed the diagnosis. Early intervention can significantly improve outcomes and reduce the risk of severe complications. So, when there's a suspicion of HSV encephalitis, don't wait for lab confirmation. Initiate antiviral therapy right away. This approach underscores the importance of timely treatment in managing viral encephalitis effectively. Let's take a closer look at the options for managing increased intracranial pressure in this patient with pneumococcal meningitis and diffuse cerebral edema. Option A suggests fluid restriction only. While controlling fluid intake can help reduce cerebral edema, in cases like this, fluid restriction alone is usually not sufficient to manage the severity of increased ICP. Option B involves using mannitol or hypertonic saline. These agents are osmotic therapies that help draw fluid out of the brain tissue, effectively reducing intracranial pressure. They are often considered first-line treatments in acute settings of cerebral edema. Option C recommends high-dose steroids for all patients. While steroids can reduce inflammation, their routine use in bacterial meningitis is controversial and not typically indicated solely for intracranial pressure control. They are more for reducing inflammation and preventing complications. Option D proposes prophylactic phenytoin for all. Although seizure prophylaxis can be considered, it's not directly aimed at lowering ICP and is not the primary intervention in this context. Finally, option E advises delaying airway intervention until arrest is imminent. This approach is risky because airway management is critical in deteriorating neurological patients to ensure oxygenation and prevent hypoxia. Considering all these points, the most appropriate intervention for this patient with diffuse cerebral edema and increasing obtundation would be to administer an osmotic agent like mannitol or hypertonic saline. These treatments can rapidly reduce ICP and are aligned with neurocritical care principles. The correct answer here is B. When dealing with raised intracranial pressure in meningitis, it's crucial to manage it effectively to prevent further brain injury. One key intervention is the use of hypertonic saline or mannitol, which helps reduce the pressure by drawing fluid out of the brain tissue. Elevating the head is also an important step, as it promotes venous drainage and helps lower ICP. If the patient is intubated, controlled ventilation is essential to maintain proper carbon dioxide levels, which can influence intracranial pressure. These strategies are all vital components of managing increased ICP in meningitis, and they work together to protect the brain while treating the underlying infection. When managing suspected bacterial meningitis, timing and the sequence of interventions are crucial. Let's look at the options presented here. Option A suggests waiting for a lumbar puncture before giving antibiotics. While this might seem cautious, delaying antibiotics can be dangerous because bacterial meningitis can progress rapidly. Option B recommends starting antibiotics only after the CSF appears cloudy. Again, waiting for clinical signs like CSF appearance can delay essential treatment and worsen outcomes. Option C advises administering IV antibiotics immediately, even before obtaining a CT scan or performing the lumbar puncture. This is often the recommended approach, especially when there's a delay in LP, to ensure the infection is treated promptly. Option D suggests giving antivirals first, which is more relevant for viral meningitis, but in bacterial cases, antibiotics are the priority. Option E recommends repeating blood cultures before starting antibiotics. While blood cultures are helpful, delaying antibiotics to do so can be risky in bacterial meningitis. In this scenario, where a patient is suspected of having bacterial meningitis, and there might be a delay in LP due to the need for a CT scan, the best course of action is to administer IV antibiotics immediately, before any imaging or lumbar puncture, because time is brain. Early antibiotic therapy improves patient outcomes and can be life-saving. So the key takeaway is that in suspected bacterial meningitis, especially when delays are anticipated, starting antibiotics promptly is the most critical step. Correct answer is C. It's crucial to remember that antibiotics must never be delayed when we suspect bacterial meningitis. Time is of the essence here. We should start with blood cultures immediately, as they can help identify the causative organism. Once we have that, administering antibiotics promptly is vital to prevent deterioration. Only after initiating antibiotics should we consider further imaging or a lumbar puncture, if the patient's condition allows. The key takeaway is that immediate antibiotic therapy can be life-saving, so delaying it for diagnostics is risky. This approach aligns with our overall goal of rapid intervention to improve patient outcomes in bacterial meningitis cases. When it comes to suspected bacterial meningitis, the key point is that antibiotics should be given immediately. Delay can be dangerous, so once suspicion arises, treatment should start right away. If possible, it's ideal to obtain blood cultures before administering antibiotics, as this helps identify the specific pathogen later on. However, it's crucial to remember that we should not delay treatment while waiting for cultures. The patient's condition is our priority, so antibiotics need to be given promptly. In cases of pneumococcal meningitis, adding dexamethasone is recommended. This corticosteroid can help reduce inflammation and improve outcomes. Now, when we're dealing with meningitis and encephalitis, especially in the ICU setting, these are high-yield situations. Because these conditions can rapidly deteriorate, timely intervention is critical, and understanding when and how to give antibiotics can make a big difference in patient outcomes. When considering a lumbar puncture, or LP, it's important to perform a CT scan beforehand if certain neurological signs are present. For example, if there's a focal neurological deficit, which means specific areas of the brain are affected and causing localized symptoms, a CT helps us rule out mass effects or other contraindications. Similarly, if the patient has new seizures, we want to be cautious and make sure there's no intracranial pathology that could worsen with the procedure. Immunosuppressed patients also require a CT prior to LP because their brains may be more vulnerable to infections or other complications. If papilledema, which is swelling of the optic disc, is observed, that indicates increased intracranial pressure, and doing an LP without imaging could be dangerous. Lastly, if the patient has reduced consciousness, a CT scan provides critical information about possible causes of altered mental status and helps us decide the safest approach. However, if none of these high-risk features are present, an LP can usually proceed without prior imaging. Focusing on meningitis and encephalitis, especially in the ICU setting, these infections are high-yield topics because they often require urgent diagnosis and treatment. Recognizing when a CT is necessary helps us avoid complications and ensures safer procedures. Remember, the overall goal is to balance prompt diagnosis with patient safety, and knowing when to image first is a key part of that. Let's talk about empiric treatment approaches for these serious central nervous system infections. When dealing with bacterial meningitis in adults, the standard initial therapy typically includes ceftriaxone combined with vancomycin. In certain cases, especially if the patient is over 50 years old or immunocompromised, we also add ampicillin to cover for listeria. It's crucial to remember that we should add dexamethasone before, or at least along with the first dose of antibiotics. This corticosteroid helps reduce inflammation and can improve outcomes by minimizing neurological damage. Now, shifting to encephalitis, the key point here is that IV acyclovir should be started immediately. Early treatment with acyclovir is vital because it targets herpes simplex virus, which is a common cause of encephalitis. Finally, both meningitis and encephalitis cases, especially in critical care settings like the ICU, require high-yield, prompt, empiric therapy to cover the most likely pathogens. This approach is essential to prevent serious complications and improve patient survival. Remember, rapid diagnosis and initiation of appropriate treatment are the cornerstones of management in these life-threatening conditions. Now, let's discuss some of the potential complications we need to be vigilant about. One major concern is cerebral edema, which can cause increased intracranial pressure. When that happens, we often use hypertonic saline or mannitol to help reduce the swelling and protect the brain. Another critical issue is seizures. These should be treated aggressively since they can worsen brain injury and complicate recovery. We also have to be aware of the possibility of septic shock and disseminated intravascular coagulation, or DIC, especially in more severe cases where infection spreads and causes systemic issues. Because of these risks, frequent monitoring of intracranial pressure and neurological status is essential. Keeping a close eye allows us to detect and address problems early. Finally, two high-yield conditions to remember are meningitis and encephalitis. These can develop in critically ill patients, so in the ICU, vigilance for signs of infection in the central nervous system is crucial for timely diagnosis and treatment. Let's talk about prognosis. Bacterial meningitis, as serious as it is, can be fatal if treatment is delayed. That's why prompt diagnosis and management are absolutely crucial. On the other hand, for HSV encephalitis, the outlook is actually quite good if we start acyclovir early. Early intervention really makes a difference here. Remember, when we're dealing with meningitis and encephalitis in the ICU, these are high-yield topics because they can rapidly become life-threatening. So, recognizing the key differences in prognosis and acting quickly can significantly improve patient outcomes. That's the overall theme here. Timing and early treatment are everything. Let's analyze this scenario more closely. We have a 48-year-old man with Guillain, Barré syndrome, or GBS, who's been admitted to the ICU. He's alert, able to speak full sentences, and his respiratory rate is 18. That's within normal limits, which might seem reassuring at first glance. But he reports feeling difficulty taking a deep breath, which is a significant symptom. Now, the question is, which parameter is the most reliable early indicator of impending respiratory failure in this context? Looking at the options, we have respiratory rate, oxygen saturation, vital capacity less than 20 ml per kilogram, chest X-ray findings, and end-tidal CO2. While respiratory rate and oxygen saturation are important, they can sometimes remain normal until the very last moment. Chest X-ray findings often change later in the process. End-tidal CO2 can be useful, but it's not as sensitive in early detection of respiratory failure in GBS. The key here is vital capacity, especially when it drops below 20 ml per kilogram. This measurement directly assesses the strength of the respiratory muscles, particularly the diaphragm. It's considered the most reliable early indicator because it can detect weakness before symptoms like hypoxia or abnormal breathing patterns become evident. So, in this patient's case, even though he appears alert and his vital signs seem stable, monitoring his vital capacity will give us the earliest warning sign that respiratory failure may be imminent. Recognizing this early allows us to intervene promptly, possibly preventing a crisis. Understanding this concept ties into the overall theme of careful respiratory monitoring in neuromuscular conditions like GBS. Early detection is crucial for timely management and better outcomes. Correct answer is C. When we look at neuromuscular failure, it's important to understand that oxygenation actually stays normal in the early stages. So, just because the patient's oxygen levels look fine doesn't mean everything is okay. The earliest signs of deterioration are actually in the reduced vital capacity, or NIF, which stands for negative inspiratory force. These measures drop before we see changes in oxygen saturation or respiratory rate. That's a key point because it helps us catch problems early before hypoxia or increased breathing rate develop. It ties into our overall theme of early detection and the importance of monitoring specific parameters to prevent rapid deterioration. Let's go through the options for managing this patient with myasthenia gravis, who is experiencing progressive weakness. Option A suggests beginning BiPAP immediately, which can be helpful in some cases to support breathing without intubation. Option B recommends intubation for airway protection and mechanical ventilation. Given his declining vital capacity to 15 ml/kg and NIF of -20 cm H2O, this indicates significant respiratory compromise. Option C is to start IV steroids only, which might be part of long-term management, but in an acute worsening like this, immediate airway support takes priority. Option D suggests delaying intervention until CO2 rises, but waiting could risk respiratory failure, so that's generally not advisable here. Finally, option E involves giving bronchodilators and reassessing. While bronchodilators may be useful in some airway issues, they won't address the current neuromuscular weakness effectively. The key point here is recognizing that with a vital capacity this low and a weak NIF, the patient is at high risk of respiratory failure. Immediate intervention, typically intubation, is often necessary to secure the airway and provide ventilatory support. This highlights the importance of early recognition and prompt action in myasthenic crisis management. Correct answer is B. When we see a ventilatory capacity less than 15 to 20 milliliters per kilogram or a NIF greater than -25 centimeters of water, that's a strong indication that intubation might be necessary. Essentially, these measurements suggest that the patient is likely to fail non-invasive support soon. It's crucial to recognize these signs early because they point to imminent respiratory failure. Remember, the goal is to intervene before the patient deteriorates further, and understanding these thresholds helps us make timely and informed decisions. This fits into the overall theme of close monitoring and early intervention to improve patient outcomes. Let's discuss the preferred ventilatory approach for a patient with neuromuscular respiratory weakness, such as Guillain-Barré syndrome, who has been intubated. When managing these patients, the goal is to provide support while minimizing additional lung injury. First, high tidal volume ventilation is generally avoided because it can cause ventilator-induced lung injury. Instead, we focus on lung protective strategies. Similarly, avoiding PEEP entirely isn't usually recommended, as PEEP helps prevent alveolar collapse and improves oxygenation, especially in these weak patients who may have compromised lung mechanics. The most effective approach here is lung-protective low tidal volume ventilation. This method uses smaller breaths to reduce the risk of barotrauma and volatrauma, which are concerns in ventilated patients, especially those with neuromuscular weakness. Hyperventilation to keep PaCO2 below 25 mmHg is not standard practice and can lead to undesirable consequences like decreased cerebral blood flow or respiratory alkalosis. Finally, prone ventilation is typically reserved for severe cases of ARDS and not routinely used in neuromuscular weakness unless indicated by specific lung pathology. So, to sum up, the best approach is to use lung-protective low tidal volume ventilation, carefully balancing support without causing additional lung injury, connecting with our overall theme of tailored, cautious respiratory support in complex cases. The correct answer here is C. When we're dealing with neuromuscular failure, it's important to remember that the lungs themselves are normal. However, because of the muscle weakness, the patient can't effectively breathe on their own. So, even though the lungs are healthy, we still need to use lung-protective ventilation strategies to prevent injury. That means avoiding unnecessary hyperventilation, which can lead to low CO2 levels, and also steering clear of high pressures that could cause barotrauma. The key is to support the patient carefully without overdoing it, ensuring we protect the lungs while managing their muscle weakness. This approach ties into our overall goal of personalized ventilation, adapting to the specific needs of each patient. Let's take a closer look at this scenario. We have a patient with known myasthenia gravis who is now presenting with respiratory failure after recent changes in their medication. Notice the pupils are small, which can be a sign of cholinergic excess, and the patient has profuse salivation, fasciculations, diarrhea, and sweating. These signs point towards a cholinergic crisis, which results from too much acetylcholine activity due to an overdose of acetylcholinesterase inhibitors like pyridostigmine. This is a critical distinction because the management differs significantly from a myasthenic crisis. In a cholinergic crisis, giving more pyridostigmine would actually worsen the symptoms, so we need to stop the medication. In fact, the key management step here is to stop the acetylcholinesterase inhibitors immediately to prevent further cholinergic excess. Now, if this were a myasthenic crisis, the priority would be to give IVIG or plasmapheresis promptly to improve neuromuscular transmission. But since the patient shows signs of cholinergic crisis, the focus shifts to stopping the offending medication and providing supportive care. Understanding these differences is essential because mismanaging a cholinergic crisis as a myasthenic crisis could lead to worsening symptoms, whereas timely recognition can be life-saving. Now, the correct answer here is B. When we talk about a cholinergic crisis, what we're really seeing is muscarinic toxicity. This manifests with symptoms like miosis, which is pinpoint pupils, diarrhea, and sweating. These are classic signs that the parasympathetic nervous system is overactivated. The key point to remember is that this condition often results from excess use of acetylcholinesterase inhibitors. In terms of management, the main step is to stop administering these inhibitors immediately. Doing so helps to reduce the cholinergic overstimulation. Recognizing these signs early is crucial, especially in patients on medications like neostigmine or organophosphates, so that we can intervene promptly. Connecting this to our overall theme, understanding the signs of toxicity allows us to differentiate between cholinergic crisis and other causes of similar symptoms, ensuring we provide the correct treatment quickly and effectively. Let's explore some key interventions that can really make a difference in the long-term recovery of patients recovering from severe Guillain, Barré syndrome who remain ventilator-dependent. First, prolonging deep sedation is generally not recommended. While it might seem helpful to keep the patient calm, extended deep sedation can hinder neurological recovery and delay weaning from the ventilator. Next, implementing daily spontaneous breathing trials as early as possible is crucial. These trials help assess the patient's readiness to breathe independently, promoting quicker weaning and reducing complications associated with mechanical ventilation. Regarding hyperventilation to reduce CO2 levels, this approach can be risky. Excessive hyperventilation may lead to respiratory alkalosis and other metabolic disturbances, so it's not typically a beneficial long-term strategy. Avoiding physiotherapy until the patient is fully awake is another point to consider. Early mobilization and physiotherapy are important for preventing muscle atrophy and promoting recovery, so delaying therapy can actually hinder progress. Lastly, stopping nutrition until the patient is extubated is generally not advised. Maintaining proper nutrition supports overall recovery, immune function, and muscle strength, so nutrition should continue as tolerated, even if the patient remains ventilator-dependent. In summary, the intervention that truly improves long-term recovery is initiating daily spontaneous breathing trials early. This approach encourages independence from mechanical ventilation and is key in the rehabilitation process. Correct answer. B. Early spontaneous breathing trials, physiotherapy, and rehabilitation are crucial components in patient recovery. They work together to improve overall outcomes by promoting lung function, strengthening muscles, and encouraging mobility. Engaging patients early in these activities can significantly reduce the time they spend on ventilators. This not only shortens ICU stays, but also decreases the risk of complications associated with prolonged ventilation. These strategies align with our overall goal of facilitating faster, safer recovery and helping patients regain independence more quickly. Let's talk about the key criteria for intubation, which is a critical decision in managing respiratory failure. First, we look at ventilatory parameters. If the vital capacity, or VC, drops below 15 to 20 milliliters per kilogram, that's a strong indication that the patient may need airway support. Next, the negative inspiratory force, or NIF, is important. If it's greater than minus 25 centimeters of water, it suggests inadequate respiratory strength. We also consider bulbar dysfunction, which includes weak cough and aspiration risk, because these issues compromise the airway and increase the likelihood of respiratory complications. Rapidly progressing neuromuscular weakness is another major sign. When weakness worsens quickly, early intervention becomes crucial. Finally, in cases of neuromuscular respiratory failure, especially in the ICU setting, intubation may be necessary to ensure adequate ventilation. All these indicators help us decide when to move forward with intubation to prevent respiratory failure and optimize patient outcomes. Let's talk about ventilation. Even when lungs appear normal, it's important to use lung protective settings. This approach helps prevent additional injury from the ventilator. Specifically, we want to avoid high tidal volumes, which can cause overdistension and damage to the lungs. Equally important is avoiding prolonged hyperventilation, as it can lead to issues like decreased cerebral blood flow and other complications. In the context of neuromuscular respiratory failure in the ICU, careful ventilation management becomes even more critical. The goal is to support breathing effectively while minimizing the risk of ventilator-induced lung injury. So, by applying these principles, using protective settings, avoiding high volumes, and preventing hyperventilation, we can improve patient outcomes and reduce further respiratory complications. Now let's talk about differentiating crises in myasthenia gravis. First, the myasthenic crisis. This is characterized primarily by weakness, but notably there are no muscarinic effects present. When this happens, the treatment options include intravenous immunoglobulin, or IVIG, or plasma exchange, both of which help reduce the immune response causing the weakness. On the other hand, we have the cholinergic crisis. This occurs when there's an excess of acetylcholine due to overuse of acetylcholinesterase inhibitors. The key features here include miosis, which is pinpoint pupils, salivation, diarrhea, sweating, and fasciculations, those small involuntary muscle twitches. A crucial point to remember is that if a patient develops a cholinergic crisis, the treatment involves stopping the acetylcholinesterase inhibitors immediately. Finally, in severe cases, crises can lead to neuromuscular respiratory failure, often requiring intensive care unit management. Recognizing these differences is vital because the management strategies are quite distinct, and misdiagnosis can lead to worsening the patient's condition. This differentiation ties back to our overall goal of providing targeted, effective treatment for myasthenia gravis crises. Now, let's talk about recovery and rehabilitation, which are crucial for patients with neuromuscular respiratory failure in the ICU. First, early spontaneous breathing trials, or SBTs, are essential because they help assess if a patient is ready to breathe independently and can significantly shorten the duration of mechanical ventilation. Next, chest physiotherapy plays a vital role in clearing secretions, preventing lung complications, and maintaining airway hygiene. Avoiding unnecessary sedation is also key. It allows patients to participate more actively in their recovery and reduces the risk of prolonged ventilator dependence. Adequate nutritional support cannot be overstated. It helps preserve muscle strength, boosts immune function, and promotes healing. Altogether, these strategies form a comprehensive approach to help patients recover and regain their respiratory independence effectively. Let's take a closer look at this table, which highlights some key features that can suggest malignant spinal cord compression. Starting with point A, worsening pain when sitting upright. This is important because it indicates that the spinal cord or nerve roots may be compressed in a way that worsens with certain positions. Moving to point B, pain that improves with rest is a classic sign, often seen in malignant causes, as activity can aggravate the pressure or inflammation. Point C describes worsening back pain when lying flat at night, which can be a red flag for spinal cord or vertebral involvement by a tumor, especially if the pain becomes more intense in a horizontal position. Then, point D lists radial nerve palsy, which refers to weakness or paralysis affecting the radial nerve distribution. This can hint at nerve root involvement or nerve compression caused by tumor spread. Finally, point E mentions isolated foot drop without sensory symptoms. While foot drop indicates motor weakness, the absence of sensory findings might suggest a specific nerve or nerve root involvement rather than widespread spinal cord compression. Connecting this to our overall theme, when evaluating a patient like this man with known lung cancer presenting with severe back pain, progressive leg weakness, and worse pain when lying down, these features are critical clues. The bilateral hyperreflexia points toward an upper motor neuron lesion, another sign that the spinal cord may be involved. Recognizing these features helps us suspect malignant spinal cord compression early, so we can act promptly to manage it. Correct answer is C. Night pain or pain that worsens when lying down is a classic sign of malignant epidural spinal cord compression. This type of pain occurs because of venous plexus engorgement, which happens when the tumor compresses the epidural veins. This leads to increased pressure and pain that tends to be worse at night or when the patient is in a supine position. Recognizing this pattern is crucial because it can be an early indicator of spinal cord compression, which requires prompt diagnosis and management. Understanding these pain characteristics helps us differentiate malignant epidural compression from other causes of back pain, and it underscores the importance of paying close attention to the timing and nature of the pain in our clinical assessments. Let's look at the options available in this urgent scenario. When a patient presents with acute urinary retention and bilateral leg weakness, the underlying concern is likely spinal cord compression, especially given her history of breast cancer. Now, the question is, what is the best immediate management before confirming with MRI? Option A suggests starting high-dose IV dexamethasone immediately. This approach aims to reduce spinal cord swelling quickly, which can be crucial in preventing permanent damage. It's often considered the standard in such emergency situations. Option B recommends delaying steroids until the MRI confirms compression. While waiting for imaging is important for diagnosis, delaying steroids might allow ongoing compression to cause more irreversible damage. Option C involves beginning LMWH anticoagulation. While anticoagulation is important in some contexts, it doesn't directly address the spinal cord compression or swelling in this case. Option D suggests starting NSAIDs only. While NSAIDs can reduce inflammation, they are generally insufficient for the severity of spinal cord compression and are not appropriate as a sole initial treatment here. Finally, option E involves observing for 24 hours to see if symptoms improve. Given the severity of bilateral leg weakness and urinary retention, observation alone would be risky and could lead to worse outcomes. In the context of urgent spinal cord compression, the most evidence-supported initial step is to administer high-dose corticosteroids promptly. This helps minimize swelling and potential neurological damage while preparing for definitive diagnosis and management. Correct answer: Now, let's talk about the use of dexamethasone in these cases. Administering a 10 mg IV bolus of dexamethasone can be very effective. After that, a typical dosing schedule is about 4 to 6 mg every 6 hours. This approach helps to reduce edema and, importantly, preserves neurological function. One key point to remember is that we shouldn't wait for an MRI before starting treatment. Early intervention with steroids can make a significant difference in patient outcomes, especially in reducing brain swelling. So the main takeaway here is that timely steroid administration is crucial, and the dosing strategy I mentioned can help stabilize the patient quickly while we coordinate further diagnostic steps. When we're considering imaging options for a patient with suspected spinal cord compression due to metastatic prostate cancer, especially in an emergent situation, it's important to choose the right modality. Now, in this case, the patient has a pacemaker, which rules out MRI because of safety concerns. MRI is typically the gold standard for soft tissue evaluation, but we need alternatives here. Looking at our options on the slide, we have several choices. A CT thorax only might give us some information, but isn't ideal for detailed spinal cord assessment. B, CT spine with contrast can provide better bone detail and some soft tissue contrast, but still may not be sufficient for detailed cord evaluation. C, CT myelogram involves injecting contrast into the spinal canal, providing excellent visualization of the spinal cord and nerve roots. This is a very useful option when MRI can't be performed. D, PET scan, is more about metabolic activity and detecting metastases, but isn't great for detailed cord compression imaging. E, ultrasound of the spine, isn't practical given the depth and bone interference. So, in this scenario, the most appropriate choice is the CT myelogram. It offers detailed imaging of the spinal cord and nerve roots without the need for MRI, making it ideal for patients with pacemakers or other contraindications. This highlights the importance of understanding alternative imaging modalities, especially in emergent cases, and how they connect to our overall goal of prompt and accurate diagnosis. The correct answer here is C. When we're evaluating spinal issues, MRI is generally considered the gold standard because it provides the most detailed images of the spinal cord and surrounding structures. However, it's important to remember that MRI isn't always an option. Sometimes there are contraindications, like certain implants or allergies. In those cases, the best alternative is a CT myelogram. This technique allows us to visualize the epidural space and detect cord compression effectively. So, understanding these imaging choices and their applications is crucial as we focus on accurate diagnosis and appropriate management. All right, let's focus on this scenario. We have a 68-year-old patient with metastatic lymphoma, and MRI confirms T6 epidural compression. He's paraplegic but still retains pain sensation. Now, the key question here is, what's the next best step for him? Looking at our options, immediate spinal radiotherapy is often considered for tumor control, but in cases of epidural compression causing neurological deficits, timing and intervention are critical. High-dose steroids alone might help reduce edema, but they don't address the mechanical compression directly. Emergent surgical decompression plus stabilization can be life-saving and may restore function, especially when there's spinal cord compression with neurological deficits. Starting chemotherapy before decompression might be beneficial in some cases, but with acute neurological compromise, waiting could risk permanent damage. Given this patient's presentation, paraplegia with preserved pain sensation, that suggests an urgent need to relieve the compression promptly. Therefore, the most appropriate next step would be emergent surgical decompression and stabilization. This approach aims to decompress the spinal cord quickly, prevent further neurological deterioration, and stabilize the spine. This scenario underscores the importance of rapid assessment and intervention in spinal cord compression, aligning with our overall theme of timely management to optimize neurological outcomes. The correct answer here is C. When we see rapidly progressing deficits, an unstable spine, or incomplete paralysis, surgical decompression tends to be the better option compared to radiation alone. These situations indicate a more urgent need to relieve pressure on the spinal cord or nerves, and surgery allows us to directly address that. Radiation can be helpful in some cases, but in these acute, severe scenarios, surgical decompression provides a more immediate and effective intervention. This aligns with our overall theme of tailoring treatment to the severity and progression of neurological deficits to optimize patient outcomes. Let's analyze this case. We have a 44-year-old man experiencing severe low back pain that radiates to both legs, along with urinary retention and saddle anesthesia. These symptoms are quite significant. They suggest a possible compression or injury affecting the cauda equina or lower spinal cord. Now, looking at the options on the table, the key features to focus on are the neurological signs. Clonus in the ankles and hyperreflexia in the legs indicate upper motor neuron involvement, which is often seen with spinal cord lesions. Saddle anesthesia and urinary retention are more characteristic of cauda equina syndrome, where nerve roots are compressed in the lumbar region. Interestingly, the option of unilateral sensory loss only is less typical here because the symptoms seem bilateral and involve the saddle area, which is innervated by both sides. And the normal rectal tone suggests that the anal sphincter control is still intact, which is a good sign, but doesn't rule out significant nerve compression. Considering all this, the most characteristic finding in this scenario is hyperreflexia in the legs, pointing toward an upper motor neuron lesion affecting the spinal cord. This ties into the overall theme of recognizing neurological signs that point to specific spinal cord or nerve root issues, helping us differentiate between diagnoses like cauda equina syndrome versus other spinal cord pathologies. So, in summary, the most characteristic clinical finding here is hyperreflexia in the legs, which helps us confirm the presence of a significant neurological lesion affecting the spinal cord. The correct answer here is C. Saddle anesthesia is a key hallmark of cauda equina syndrome. This condition occurs when there's compression of the lumbosacral nerve roots, which affects the areas that typically feel sensations on the inner thighs, buttocks, and perineum. Recognizing saddle anesthesia is crucial because it signals a potentially serious problem. When we see this, it indicates that urgent imaging, specifically an MRI, is needed to confirm the diagnosis and assess the extent of compression. Time is of the essence here because prompt decompression can prevent permanent neurological damage. So, in summary, identifying saddle anesthesia helps us quickly move to the right diagnostic and treatment steps to protect the patient's neurological function. Let's take a closer look at some of the common etiologies or causes of spinal cord issues. One major category is metastatic cancer, which can originate from primary tumors in the lung, breast, prostate, or lymphoma. These cancers can spread to the spine and cause compression or damage to the spinal cord. Another important cause is epidural abscess, which is an infection that develops in the space around the spinal cord. This can lead to inflammation and pressure, resulting in neurological symptoms if not treated promptly. Trauma is also a significant factor. Any injury or fracture to the spine can compromise the spinal cord's integrity. Similarly, disc herniation can impinge on the spinal cord or nerve roots, causing pain and neurological deficits. Hematomas, which are collections of blood, can occur post-procedure or due to anticoagulation therapy. These blood collections can exert pressure on the spinal cord and need urgent attention. Lastly, spinal cord compression in the ICU setting is often due to various factors like swelling, bleeding, or tumor progression, and it requires immediate diagnosis and management to prevent long-term deficits. All these etiologies highlight the importance of understanding the different causes we might encounter, especially when assessing patients with neurological symptoms related to the spine. Let's go over some critical red flags to watch for in patients presenting with back issues. First, severe back pain that worsens when lying down is a red flag because it can indicate serious underlying pathology. Next, Bilateral leg weakness suggests that there might be nerve or spinal cord involvement affecting both sides. Sensory level abnormalities are also crucial. They can point to spinal cord compression or other neurological issues. New urinary retention is another serious sign. This could mean the nerves controlling bladder function are compromised, which requires urgent attention. Hyperreflexia, or increased reflexes, can be a sign of spinal cord irritation or injury. Saddle anesthesia, which is numbness in the areas that would touch a saddle, is characteristic of cauda equina syndrome, a true emergency. Finally, spinal cord compression is a critical condition that often necessitates ICU-level care to prevent permanent neurological damage. Recognizing these red flags early is vital because they indicate potentially life-threatening or limb-threatening conditions that demand immediate evaluation and intervention. These signs are essential to keep in mind as we continue to discuss spinal emergencies and their management. When it comes to emergency management, every second counts, so do not delay treatment. Immediately administering IV dexamethasone is crucial. Start with a 10 mg bolus and then follow up with 4 to 6 mg every 6 hours. This helps reduce inflammation and prevent further neurological damage. Next, it's important to get imaging quickly, either a whole spine MRI if it's safe, or a CT myelogram if the MRI isn't an option. Rapid imaging guides us in understanding the extent of the compression and planning appropriate interventions. Consult neurosurgery and radiation oncology as soon as possible. These specialists are vital in determining the best course of action, whether surgical decompression or radiation therapy, to relieve the compression and preserve neurological function. If the patient has spinal cord compression, this is a critical situation that often requires ICU management. Here, close monitoring and supportive care are essential to optimize outcomes and prevent permanent deficits. Overall, prompt recognition and immediate intervention are the cornerstones of effective emergency management in spinal cord compression. When it comes to definitive treatment, surgical decompression is often the go-to approach in certain critical situations. For example, if a patient is experiencing rapid neurological decline, we need to act quickly to relieve pressure on the spinal cord. Similarly, if the spine is unstable, surgical stabilization becomes necessary to prevent further damage. In cases of incomplete paralysis, decompression can sometimes restore function or prevent worsening. On the other hand, radiotherapy plays a vital role, especially for tumors that are radiosensitive. If a tumor responds well to radiation, we can use radiotherapy to control the growth and alleviate compression without surgery. This is also particularly important for patients who are not good candidates for surgery, those who might have other health issues or risks that make surgical intervention too dangerous. In the ICU setting, when we see spinal cord compression, timely and appropriate treatment, whether surgical or radiation, is crucial to prevent permanent deficits. The key takeaway here is that the choice of treatment depends on the patient's condition, the tumor's characteristics, and the urgency of neurological symptoms. Overall, the goal is to preserve or restore neurological function and stabilize the spine to improve patient outcomes. Let's talk about cauda equina syndrome, which is a true emergency. If a patient presents with symptoms like saddle anesthesia, that's numbness in the area that would sit on a saddle, this is a big red flag. Urinary retention, or the inability to urinate, is another critical sign we can't ignore. Loss of anal tone, meaning the inability to control bowel movements, also points to a serious problem. Additionally, bilateral radicular pain, which is pain radiating on both sides down the legs, is a warning sign. When we see these symptoms, urgent MRI imaging is essential to confirm the diagnosis. Remember, time is of the essence here because early surgical intervention can be crucial in preventing permanent deficits. If spinal cord compression is confirmed, especially in ICU settings, prompt surgical decompression becomes necessary to relieve pressure and preserve neurological function. Overall, recognizing these key signs quickly and acting fast with imaging and surgery can make all the difference in patient outcomes. Let's walk through the key points here. In this scenario, we have a 58-year-old man brought to the ICU with a Glasgow Coma scale score of 5, which indicates a severe impairment of consciousness. His eye opening is to sternal rub, but there's no verbal response, and he has some motor response, though not purposeful. His pupils are equal and reactive, which is a good sign. His blood pressure is stable at 140/80. Breathing is slightly slow at 10 breaths per minute, and his oxygen saturation is 93% on room air. Now, the important thing to focus on here is the patient's level of consciousness and the pending CT head. Given his GCS score and clinical presentation, the priority is to secure his airway to prevent hypoxia or aspiration. Oxygenation and airway protection are critical in such a severely impaired patient. Looking at the table, the immediate actions include obtaining an emergent CT head, which is essential for diagnosis. But before that, we need to ensure airway stability. Administering naloxone could be useful if we suspect opioid overdose, but there's no known history or signs pointing to that. Intubation for airway protection is crucial because with a GCS of 5, his airway is at risk of compromise. Starting mannitol is important if we suspect increased intracranial pressure, but that is a step after ensuring airway and breathing are managed. Performing a lumbar puncture is not an immediate priority here, especially with the severity of his neurological status. So, the most important immediate action is to secure his airway through intubation. This will ensure he maintains adequate oxygenation and ventilation while we proceed with diagnostic and therapeutic interventions. Correct answer is C, intubate for airway protection. Any patient with a Glasgow Coma scale of 8 or less requires immediate airway management. This is a crucial point because their airway could become compromised, and securing it promptly can be life-saving. Remember, the priority is to protect the airway first, before moving on to other interventions. Once the airway is secured, then we can proceed with CT imaging and treating reversible causes of the neurological impairment. So, the key takeaway here is that airway protection takes precedence in these critically impaired patients. It's a fundamental step in managing patients with severe neurological deficits. Let's look at the options for managing this patient. We have a 70-year-old woman with diabetes who's found unresponsive, with a GCS of 6, reactive pupils, and no signs of trauma. Her blood glucose is critically low at 1.8 mmol/L. The key here is recognizing that hypoglycemia is a common and potentially life-threatening cause of unresponsiveness in diabetic patients. Rapid correction of her low blood sugar is essential. Now, considering the options, giving an IV dextrose bolus would be the most immediate and effective way to restore her glucose levels. It directly addresses the hypoglycemia, which is likely the main culprit here. Other options, like a CT brain scan, might be necessary later if we suspect a neurological cause, but in this acute setting, hypoglycemia takes priority. Administering thiamine before dextrose is important if we suspect Wernicke's encephalopathy, but since her blood glucose is dangerously low, correcting hypoglycemia should come first. Naloxone is used for opioid overdose, but there's no evidence here suggesting opioids are involved. Starting vasopressors might be needed if she remains hypotensive after correcting her glucose, but again, the immediate concern is her hypoglycemia. So, in this scenario, the most appropriate next step is to give her an IV dextrose bolus to quickly raise her blood glucose and improve her responsiveness. This approach aligns with the overall theme of rapid stabilization in emergency management. Correct answer, C, give thiamine then dextrose. In any situation where there's a suspected risk of Wernicke's encephalopathy, like in elderly patients, those who are malnourished, or diabetics, it's crucial to give thiamine before administering glucose. This is because giving glucose first can actually precipitate or worsen Wernicke's encephalopathy if thiamine levels are low. So the key point here is to give thiamine, typically 100 mg IV, before you give any glucose. After that, you can follow with a 50% dextrose bolus safely. This sequence is really important to prevent potentially serious neurological complications, and it ties into the overall theme of managing at-risk patients carefully to avoid iatrogenic harm. Let's take a closer look at this scenario. We have a patient who is comatose after cardiac arrest, and their pupils are fixed and dilated. The corneal reflex is absent, and the Glasgow Coma Scale score is 3, which indicates deep coma. Since the patient is off sedation, we can rule out medication effects. Now, these findings, fixed, dilated pupils, and absent corneal reflex, are quite significant. They strongly suggest that there's brainstem dysfunction, particularly involving the midbrain or pons, which are critical for pupillary reflexes and other vital reflexes. This pattern is more indicative of a severe brain injury rather than psychogenic causes or cortical dysfunction alone. It points toward a condition called brain death, or a very severe anoxic brain injury where the brainstem is compromised. Recognizing these signs is crucial because they help us differentiate between different types of brain impairment. Understanding this pattern aligns with our overarching theme of neurological assessment in coma, pinpointing whether the issue lies in the cortex, brainstem, or elsewhere. It's essential to interpret these signs carefully to guide prognosis and management decisions. The correct answer here is B, brainstem dysfunction. When we see a loss of pupil and corneal reflexes, that's a strong sign that the brainstem is involved. And this is really critical because brainstem involvement typically indicates a very poor prognosis. Now, it's important to understand the difference between injuries. If the injury is limited to the cortex, the brain's outer layer, the brainstem reflexes, like pupil light response and corneal reflex, are often preserved. But when those reflexes are lost, it suggests that the injury extends deeper, affecting the brainstem itself. This distinction helps us gauge the severity and potential outcomes of neurological injuries. Remember, the preservation or loss of these reflexes can tell us a lot about the underlying damage and help guide our prognosis and management strategies. Let's go through the options here. First, assuming a structural brain injury and calling neurosurgery is a critical step if we suspect a significant injury that requires surgical intervention. However, before jumping to that, we need to gather more information. Performing a CT scan of the head right now is often the quickest way to identify any intracranial pathology, such as hemorrhage or mass effect, especially in a patient who remains unresponsive after sedation is stopped. Waiting longer to allow drug clearance might be tempting, but in this case, time is of the essence because we need to rule out any acute structural issues. Starting mannitol is an option if we suspect increased intracranial pressure, but again, we need to confirm the diagnosis first. Performing a lumbar puncture to rule out meningitis is generally not advisable in a patient with suspected intracranial pathology, especially if there's a risk of increased pressure or mass effect, which could lead to herniation. So, considering all these points, the most appropriate next step in this scenario is to perform a CT head now. It's a rapid, non-invasive way to assess for structural causes of the unresponsiveness and guide further management. Correct answer: C. Wait longer for drug clearance. Midazolam and fentanyl, as many of you know, have variable elimination, especially in ICU patients who often have organ dysfunction. This variability means we need to be cautious when assessing sedation levels and drug clearance. Sedation holidays, which are periods where we pause sedation to evaluate neurological function, often require hours, not just minutes, to be effective. It's important to recognize that if there are no red flags like asymmetry or signs of brainstem loss, we should continue observing carefully. Overall, the key takeaway here is to allow sufficient time for drug clearance before making decisions, ensuring patient safety and accurate assessment. Let's analyze the case. A 63-year-old man remains in a coma 72 hours after experiencing a ventricular fibrillation arrest outside of the hospital. Targeted temperature management was applied to protect his brain, and he's now off sedation, which is important for accurate neurological assessment. His EEG shows burst suppression, which indicates significant brain activity suppression, often seen in severe brain injury or after therapeutic hypothermia. Additionally, his pupils are absent bilaterally, suggesting deep coma and potential brainstem dysfunction. Given these findings, the most appropriate interpretation is that his prognosis is quite poor. The absence of pupillary reflexes coupled with burst suppression on EEG points toward a severe neurological injury, and the likelihood of meaningful recovery is low. In this context, the best course of action would be to recognize the poor neurological prognosis and consider appropriate supportive care, possibly including discussions about goals of care with the family. This scenario underscores the importance of integrating clinical exam findings with neurophysiological data to guide prognosis after cardiac arrest. Let's look at the correct answer here. C. Poor neurological prognosis. After we rewarm the patient and clear the sedation, certain signs can give us important clues about their neurological outcome. For instance, absent pupils combined with a burst suppression EEG pattern are strongly indicative of an extremely poor prognosis. However, it's crucial to remember that these signs do not mean the patient is brain dead. Brain death requires a formal, specific set of tests to confirm. So, while these findings are significant and suggest a very unfavorable outlook, they do not replace the definitive testing needed to establish brain death. This distinction is important in guiding clinical decisions and family discussions. All right, let's talk about what a coma actually is. A coma is essentially a state of unarousable unresponsiveness, meaning the person can't be awakened, even with vigorous stimulation. When we measure their level of consciousness using the Glasgow Coma Scale, or GCS, a score of 8 or less indicates a coma. This is a crucial point because it helps us objectively assess how deep the unconsciousness is. Understanding this definition is fundamental as we explore disorders of consciousness, because it sets the baseline for recognizing the severity of brain impairment in these cases. So, in summary, a coma is a profound state where the patient is completely unresponsive, and GCS less or equal to 8 is the key marker for this condition. Let's start by emphasizing an important point. Do not delay airway management for imaging. Securing the airway takes priority to prevent hypoxia and further brain injury. Now, moving on to the immediate priorities, which follow the ABCD approach. First, airway. If the patient has a GCS of 8 or less, intubation is essential to maintain a patent airway and ensure adequate oxygenation. Next, breathing. Assess their ventilation status and obtain an arterial blood gas to evaluate oxygen and carbon dioxide levels. This helps us determine if they need ventilatory support or other interventions. Then, circulation. It's crucial to identify and correct shock promptly. This involves checking blood pressure, heart rate, and perfusion, and administering fluids or medications as needed. Finally, dextrose. Always check blood glucose immediately. Hypoglycemia can cause or worsen a coma, so swift identification and treatment are vital. In managing coma or disorders of consciousness, these steps are the foundation. Remember, addressing airway, breathing, circulation, and glucose quickly can make a significant difference in patient outcomes. These priorities are central to stabilization and further assessment. Let's take a closer look at the key causes that can lead to coma and disorders of consciousness. First, we have metabolic causes. These include issues like hypoglycemia, which is dangerously low blood sugar, hypernatremia, or high sodium levels, hepatic encephalopathy, a brain dysfunction caused by liver failure, and uremia, which results from kidney failure. These metabolic disturbances can significantly impair brain function if not promptly identified and managed. Next, we have toxic causes. Substances such as opioids, benzodiazepines, and alcohol are well known for their depressant effects on the central nervous system. Overdose or intoxication with these agents can depress consciousness, sometimes leading to coma. Then there's structural causes. These involve physical damage to the brain, including stroke, intracerebral hemorrhage, traumatic brain injury, or herniation. Such structural injuries can disrupt normal brain activity and consciousness. We also need to consider post-cardiac arrest situations, where hypoxic brain injury occurs due to lack of oxygen during cardiac arrest. This hypoxia can lead to significant brain damage and coma. Finally, seizures, particularly nonconvulsive status epilepticus, can also cause profound alterations in consciousness. These seizures may not have obvious physical signs, but can severely impair brain function if not recognized and treated. All these causes are interconnected with the overall theme of understanding how various factors, metabolic, toxic, structural, or due to injury, can impact consciousness. Recognizing these key causes is essential for accurate diagnosis and effective management of coma patients. When approaching a patient with coma or disorders of consciousness, it's crucial to have a structured diagnostic plan. First, we start with point-of-care glucose testing to quickly rule out hypoglycemia, which is a common and reversible cause of altered mental status. Next, we look at arterial blood gases, electrolytes, and ammonia levels to identify metabolic disturbances, acid-base imbalances, or liver issues that could be contributing. If we suspect a structural brain problem, such as a bleed or mass, a CT head scan is essential for rapid diagnosis. It helps us visualize the brain's anatomy and identify any acute lesions. Similarly, if there's suspicion of seizure activity, an EEG can provide valuable information about abnormal electrical activity that might not be evident clinically. In addition, assessing all brainstem reflexes is a key part of our exam. These reflexes help us gauge the integrity of the brainstem and can provide clues about the level and location of brain dysfunction. Altogether, this approach allows us to systematically narrow down the potential causes of coma and tailor our management accordingly. Let's talk about some of the poor prognostic indicators we look for in patients with coma or disorders of consciousness. First, the absence of pupillary and corneal reflexes is a significant warning sign. When these reflexes are missing, it suggests severe brainstem dysfunction, which often correlates with a poor outcome. Next, an EEG showing burst suppression or being unreactive to stimuli is another critical indicator. These patterns typically reflect extensive brain injury and a diminished likelihood of recovery. Additionally, if bilateral N20-SSEP potentials are absent, it points to significant damage in the somatosensory pathways, which again is associated with a worse prognosis. And finally, if there's no motor response observed 72 hours after cardiac arrest, especially in the absence of sedation, that's a very concerning sign. It indicates a profound level of brain injury with limited chances of meaningful recovery. Connecting all these points, they help us identify patients with the most severe brain injury, guiding our prognosis and management decisions. Recognizing these poor prognostic indicators is crucial for making informed, compassionate discussions with families and planning appropriate care pathways. Let's talk about some important points to remember when evaluating a patient with a suspected coma or disorder of consciousness. First, do not misinterpret certain conditions that can mimic coma. For example, sedation is a common one. Patients who are sedated may appear unresponsive, but they are not truly in a coma. Similarly, hypothermia can depress brain function enough to look like coma, but it's a reversible condition once temperature is managed. Paralytics are another key factor. They can cause paralysis and unresponsiveness, but they don't indicate brain dysfunction. It's crucial to recognize these conditions because they can easily be mistaken for true coma. Understanding these mimics helps us avoid misdiagnosis and ensures we treat the underlying cause appropriately. Remember, the goal is always to distinguish between actual brain injury and conditions that simply look like it on the surface. Thank you so much for your attention today. I really appreciate your time and engagement throughout this presentation. I hope the insights shared here have been valuable and have helped to reinforce the key points we've discussed. Remember, The ideas and strategies we explored are all aimed at driving positive change and growth. If you take away anything from today, let it be the importance of applying these concepts thoughtfully and actively. Once again, thank you for being here and for your commitment to continuous learning and improvement.